the spaces, triangles, interval from the front and the back, I think probably I find it easier to identify these structures from the posterior perspective. But in any case, know what neurovascular structures pass through those spaces, intervals, or triangles. And in addition, I would encourage you again to think of the two teres muscles and the lateral and the long head of the triceps as being your defining structures, your delimiting structures. And then you have, in this particular illustration, you also have a nice summary of the contents of each. The only problem I have with this illustration is it's from the front, so it's a little bit difficult to see all of the delimiting structures. So we've talked about the suprascapular nerve. Remember, the suprascapular nerve is important in innervation of the spinatus, supraspinatus and infraspinatus. The axillary nerve, we indicated, innervates the deltoid for the most part. It also innervates the teres minor. And then there's a bit of a debate about the contribution of the axillary nerve to the triceps muscle. The modern contention is that the axillary nerve also innervates the motor branch of the long head of the triceps. However, in virtually every textbook, you're going to read that the triceps is innervated by what nerve? Anybody know? The radial. So please make a note somewhere, because I think I have it in a couple of slides here, that whether you want to tell me that the triceps are innervated by the radial or a combination of the radial and the axillary, that's fine. I'm not in a position to controvert the published literature. But I think most of the empirical evidence suggests that the long head is innervated by the axillary. Now remember, when we talk about the triceps, there are three heads here. There's a long, lateral, and medial. The long head is the only one that goes up to the scapula. The other two only go to the humerus across the elbow. Remember, I told you about the confusion here. Is this see what I'm talking about? So this was called the transverse cervical, and here it's called the dorsal scapular. In reality, there is an anatomical distinction, but apparently certain anatomists are still feuding about this and have been since the 1980s. So I'm not going to entertain that debate. Just be aware that, again, you can use either term. More importantly, as you see here, and as we saw in the previous illustration, there is extensive interconnection between that artery, whatever you want to call it, and the suprascapular. And there's also a number of, excuse me, a number of efferents from the axillary. Of course, the axillary originated from the subclavian, and then distal to the teres. Teres major becomes the brachial, so it's brachial down here. But you can see there are a number of efferents giving rise to branches that perfuse this entire region. In fact, we talked about this one before. Remember, this posterior circumflex is vulnerable to injury with any trauma to the surgical neck of the humerus because of its precarious position there. All right, let's talk a little bit about the mechanical assemblage of the shoulder. Now, there are several slides here in which you have illustrations of both ligaments and tendons. And in some textbooks you will read, and much of your clinical literature you will read, for example, where you're focusing on tears and injuries to tendons in the shoulder, that the glenohumeral joint or the shoulder joint is only weakly encapsulated by ligaments, and therefore what's the structures that are holding your arm to your thorax are chiefly muscles and tendons. And that's fine. I don't think there's anything wrong with that contention, but it should not allow you to overlook the rather extensive array of ligaments that are present. Now remember, in general, in joints, and these synovial joints, we call these ligaments the external capsule. So you still have an external capsule. We're sort of looking at this anterior. This is the anterior view, and the external capsule is much more extensive on the anterior side than it is on the posterior side. And as far as these terms go, I think you know that the clavicle attaches to the sternum and the acromion. See it there and there. So just be aware of those terms that are used to describe those ligamentous connections. These are binding ligaments. These are sometimes called collateral ligaments. Remember, a collateral ligament is a ligament that extends from one bone directly to an adjacent bone and binds them together to one degree or another. So both the sternoclavicular and the acromioclavicular are transverse or collateral ligaments by that definition. Now, the shoulder joint is technically termed the glenohumeral joint, and you begin to sense, and you probably want to look at several of these illustrations to get an idea of this, but that's the extent of the articular cartilage on the scapula. And so all of this articular cartilage on the head of the humerus is being moved, at various, in the range of motion of the joint along that rather small scapular articular surface. And as we've seen before, with these type of synovial joints, that purple region, that lavender region there, that's the synovial component, that's the synovium. You can see that that would be filled with lubricating synovial fluid. And that capsule, with the integrity of that capsule, should be maintained in order to ensure smooth and lubricious movement of the joint. Remember, in our discussion of the hip joint, we encountered the labrum. Well, there's also a labrum here called the glenoid labrum. That acts sort of as a seal for that scapular articular surface. That's frequently compromised, especially as I think you can see. This is a little more vulnerable than the hip joint because of this rather small range of articulation on the scapular side. And the muscles that are most important in attaching the arm to the shoulder are the rotator cuff muscles. We'll look at in just a moment. You can see one of them here, the supraspinatus, which we talked about, is important for initial adduction, the first 10 to 15 degrees of abduction of the arm, and then the deltoid over here, which is a more powerful muscle. So, as I say, look at several of these illustrations. You have different representations of the synovial component. This would be the synovium, and this intervening space there would be filled, the articular cavity would be filled with the synovial fluid. And you can see what we're calling the external capsule. Here they're calling, you often see it called this, the fibrous layer. So the external capsule and the fibrous layer can be used interchangeably if that's a source of confusion for you. Unfortunately, in the illustration on the right, the ligaments are colored purple here. So all of this is ligamentous tissue. And that, which I colored with the red ink there, corresponds to this. So you just have several of these, what are called glenohumeral or anterior ligaments. But what should be very evident to you is that that articular surface only occupies a significant portion, but not the entirety of the glenoid fossa. It's rather small, and in part, this is the problem, or part of the problem with the stability of this joint. I reposted this morning. If you don't have this, this is fine, but I put it up again this morning. It may take a while for it to propagate to all the servers around the world, which I own. But I just wanted to make sure we're looking at the shoulder joint from the anterior side here. And once again, my point in including this is to obviate or supersede the typical description of the shoulder joint as being devoid of powerful or substantial ligaments. There are ligaments here. They're very significant on the anterior side, but they're kind of thin, I will acknowledge, and I'm not sure that they could be relied upon for the integrity of the joint, especially a joint that is it is prone to such powerful muscular motions, both from the latissimus and the pectoralis, the rotators. We talked about the deltoid up there. So This is not, these rather thin ligaments are more of a capsule than contribute to the structural integrity of the joint. But in addition, and I think you should be able to do this without any problem at this point, if you see a term such as coracoacromial, you should have no trouble being able to identify that structure just based upon your knowledge of where the coracoid process and the acromia are located and so on. Coracoclavicular, yeah. So that's really what I want you to be able to do in a summer review course like this. So here we can see this is not a fried chicken dinner's preparation. What we're looking at here is the head of the humerus. You can see the articular cartilage on the head of the humerus, and of course you can probably harken back to that replacement surgery that we saw in the hip. But the same sort of arrangement. You have the glenoid fossa, which is the articular surface on the scapular side. Here is the labrum, and as we saw with the hip replacement surgery, that all of that would be removed in a prosthetic procedure. All of this would come off, that would be reamed out, and the labrum would be removed, and appropriate prostheses would be inserted. Yeah.
Is the biceps tendon continuous with the glenoid labrum?
Not really. So you're looking at this. We normally say that the long of the biceps tendon attaches to the supraglenoid tubercle. I'm not sure what to tell you there, except that I don't know that that would be an accurate anatomical description there. And here we're looking at the rotator cuff muscle, so be sure that you can identify these. This is on the posterior side at the top here, so you can see the supraspinatus, infraspinatus. You can see down here the teres minor. And that leaves only the large anterior muscle, the subscapularis that you see there. Once again, these rotator cuff muscles are prone to injury, and especially at the tendons here, and this is the one that usually is damaged first, that supraspinatus tendon, because of the typically unnatural forces that it must sustain in throwing motions, in lifting motions. Again, I think of these arm lifts. I know back when I was young, they would always tell quarterbacks and pitchers to do arm lifts with dumbbells. And the more weight you can do, the better. And I'm sure you can see the consequences. That can cause or occasion irreversible tendonitis or damage to the tendons, especially those vulnerable, relatively weak tendons at the superior margin of the joint. As we saw on the hip, there are a number of bursae here. These are, in this particular illustration, it would seem to me a little larger than they are typically portrayed. But these bursa, as we have seen before, are little cushioning capsules of gelatinous fluid positioned at various points, chiefly to eliminate or minimize the abrasion between adjacent tendons, or to serve as a protective capsule for any type of external trauma. And so, for example, you see the subacromial bursa there, the subscapularis bursa, and so on, located in the glenohumeral joint. These two, as we've indicated before, can become inflamed and very painful, especially with repetitive type movements. So we've seen this term before, and we've talked about, we sort of implicated, or we sort of hinted at the vulnerability of this joint to rotator cuff injuries. Here you can see a rotator cuff tear there involving the supraspinatus, and that's the most common one to occur. Now, in the illustration, we talked about the problems with tendons and ligaments. So here's this tendon being attached here, and so let's say they've been inflamed and perhaps tearing away from the bone. How did they correct it? Yeah, suture. Now, you're a PA now. For what type of patient might this be appropriate as opposed to patients for whom it might not be appropriate? What would your thinking be along those lines? We already know this is poorly vascularized tissue. It's not likely to. Usually, what they have to do, even in a repair like this, you have to cut out a portion of it and tie undamaged tissue.
Younger people?
Younger for which procedure? This would be appropriate for younger, you're saying?
Yeah.
All right, let's think about it. Younger person probably has a long life ahead of them. Probably, if you tell them they're your offspring, you tell them, hey, you can't play football anymore, you can't throw the baseball anymore. They're just going to go out and around the back of the house and do it anyway. So my point is, this would be a very conservative treatment. Probably would not be designed for a person with a long life ahead of them that's very active, and you know that they're going to be active, mainly because this is going to rip away. So generally, there are more aggressive types of treatment that might be implicated. I just want you to be aware that oftentimes a simple procedure like this may not be long lasting, and unless it's a very inactive elderly person, it might not be desirable. In some cases, I think probably what you're suggesting is that there would be greater capacity of repair in this tissue. It all depends. I'm sure the extent of the injury, the nature of the injury, the relative fitness and health of the individual, whether they're going to pursue a career in professional athletics, all of those things would inform the decision.
The rotator cuff is located in the shoulder.
Whoops. Let's see if I can get the volume up there.
The rotator cuff is located in the shoulder. It is made of muscles and tendons that connect the upper arm bone, or humerus, to the shoulder blade, or scapula. They form a ball and socket that work together to create the most flexible joint in your body. Age, poor posture, injury, and excess lifting can increase the risk of damage to the rotator cuff. Injury can cause the tendons to become inflamed, and left untreated, can become torn. Typically, rest and exercise therapy will help heal an injured rotator cuff.
Again, if the individual does not resume the activity that was responsible for the injury. And just keep in mind that there are all sorts of miracle procedures now involving, even in some cases, allografts and procedures whereby tendinous tissue can be replaced. This is more true probably for the distal leg than the arm or than the shoulder. That can be done at times. Now, the other problem with the shoulder joint, the glenohumeral joint, is that it's very prone to dislocation. How many movies have you seen? Probably some of you suffered dislocations. Anybody suffered a dislocation of the shoulder? And you probably found it painful. Areas that depend on, I'm sure, like Mel Gibson, who does this on a daily, hourly basis, and then walks up to a wall and then macho style pushes it back in, or finds someone like that, throw it back in and forth. But you probably had, in both cases, you probably had to have it reduced professionally. You went, or did it pop into place on its own?
No, I did it.
Huh? Oh, you did. Well, Mel, how'd you do it?
Put it around my knee a couple times and yanked on it. I grabbed a weight and let it yank and turn itself back in.
Hopefully, you will not recommend this to your patients. Is this something that's happened more than once?
Yeah, I think it happened about a little over a dozen times before I had surgery on it.
So it's been stated the surgery was beneficial and helpful?
Yes.
Oh, okay.
And they overcorrected, so I have really difficult issues with external rotation.
So your range of movement is limited?
Yes.
By pain or just structure?
Some pain, but just apprehension. You know, if I put it at 90 degrees, it feels like if, a fly hits it, it feels like it just ripped right out.
And I'm sure they probably, after the procedure, they probably put you through a full course of physical therapy and that sort of thing.
Yeah.
Well, yeah, the dislocation, and of course, is afforded or likely to occur by virtue of the limited external capsule. That fibrous capsule is not so robust as we've indicated. Most of the rotator cuff muscles are not terribly powerful either, so it's a very vulnerable joint. given that you really don't have a true ball and socket. You have a ball there, but there's not much of a socket, very much just a flat surface, rather analogous to the tibial component of the knee. And then if you think about it too, we're going to talk about the axilla in a moment. The axilla is this region between your underarm and the top of actually the lower portion of your shoulder. But as you elevate your arm, just think about all of those nerves and vascular structures stretching and relaxing, and then think of the mechanical attrition that this joint with all these structures attached are susceptible to. Well, it's a very common type of injury. She gave me her permission to include this photo. She was apparently running around a swimming pool. This was a PA student years ago, running around a swimming pool, which we all know we shouldn't be doing that. And she slipped, and the consequences of her fall were this. And you can see that's not quite a normal joint. If you look at the X-ray here, see if you see anything abnormal about the X-ray. Everybody see where the things should be as opposed to where they are, and so that's quite a remarkable. Well,
I think they say most like 90% are anterior, even though they feel like they go out the back, they come out the front.
yeah, that would be my guess, just because of the relative opacity on the.
You have a lateral shot.
It's possible because you do have what is that structure? In any case, I would hope this was reduced professionally. Let the lid strong man tell us how to avert it. We had a lady working with this lab a few years ago.
Today we're talking about how to treat a shoulder dislocation. Obviously this is a traumatic event. It's not a gradual thing that happens. But on the x-ray here you can see the humeral head is not in the socket. The humeral head is supposed to be here. It's in this position. Many times after a shoulder dislocation occurs, the muscles go into sort of a tetanic contraction and they go into muscle splinting. So it's hard to put the shoulder back in. Sometimes patients have to be taken to the emergency room to have the medicine so they can relax the muscles. Once the shoulder's back in, then we work on strengthening of the shoulder. Again, when you dislocate your shoulder, the ball comes completely out of the socket. Anterior dislocations are the most common. Probably 80% of the dislocations are anterior. And what it does is it tears these capsulo-ligamentous structures here, and they don't heal back. Once they're torn, they're torn. But the difference between the shoulder and the knee is that you can survive without some of your ligaments attached, because the rotator cuff is so important to stability in the shoulder joint. Strengthening of the rotator cuff is very, very important. So the motion to avoid if you have a shoulder dislocation is this motion.
I think it's too late at that point.
Okay, this position is what's going to cause your shoulder to re-dislocate. So we avoid that motion. Coming across your chest is typically not a problem, but this up and back position is what we want to avoid with the shoulder dislocation. Now the other thing we do is we work on strengthening the rotator cuff. The muscles in the back and the front of the rotator cuff are the most important because the resultant force of these forces is compression. So everything we do in strengthening for a dislocated shoulder is designed to compress the ball into the socket so when you lift your arm it stays put. Otherwise it will slide around and cause you to have problems. If you're a throwing athlete, overhead athlete, you may have to have surgery to fix this problem, to tighten up the capsule in the front, because that's such a violent maneuver. Rotator cuff strengthening may not be able to resolve your problem.
And there are procedures for repairing those ligaments. As we've indicated, the tendons are a little more difficult just because of the mechanical strain. And so he was pointing out that one potential therapy, physical therapy, is simply to strengthen the rotator cuff muscles to compensate for the destruction or the damage to the ligamentous capsule. All right, so in this illustration, we already saw the motions of the scapula earlier. Here you just see some of the muscles that contribute to elevation and depression of the scapula. Remember, the scapula is also capable of rotation, both lateral and medial rotation. And for example, the rhomboids and the serratus would contribute to that movement.
This anatomic total shoulder arthroplasty is aimed at improving glenoid exposure and prosthesis insertion.
All right, so as before, rather than, as we have lunch coming up, so we don't want to spend maybe all the time looking at this. But what do we mean by, he talked about capsular releases, what do we mean by that? He's going to insert a prosthesis, and everything's been ripped out, and in order to do that, what is a release? Yeah, you're cutting away ligaments and bones, anything that might interfere with your procedure. And then glenoid exposure, he's just talking about making that or rendering that glenohumeral joint accessible for the insertion of the prosthesis.
Releases for glenoid exposure include those on the humeral side. They are the rotator interval,
So that would be the lateral side.
coracohumeral ligaments, subscapularis and inferior capsule, long head of the biceps, and then with a Holman retractor through the supraspinatus, the cuff can be everted
Pushing it out.
for more complete visualization. On the glenoid side, the labrum is excised. There's a complete capsular release, including the origins of the long head of the biceps and triceps, impaction grafting for the keeled glenoid component, and a triple cement impaction technique. The subscapularis closure involved.
So that part's not so. But you see, there's a lot of work, a lot of structures. And by the way, release doesn't necessarily mean cutting. In some cases, it can mean just moving to the side, but in some way, preventing those structures from obstructing the procedure. In most cases, it does involve cutting.
Captured loops.
All right.
The arm can be externally rotated, and the rest of the inferior capsule and posterior capsule is then released. With a Holman through the supraspinatus and a Dara keeping the head off of the coracoid, the head is exposed, the remaining osteophytes are removed,
Yeah, the bone
and with
spurs
a
on
ring
the-
cutting guide to protect the posterior cuff, an exact cut can be made. Wafer cuts permit bone graft for the glenoid later on from the
Is
humerus.
that duct tape on his?
The stem is prepared in a standard manner for a press-fit humeral component. The version and inclination are marked.
See, very similar to the hip.
The humerus is broached. The trowel humerus is placed. And then the eccentric head is rotated into the appropriate position. A cut protector in the humeral stem prevents injury to the proximal humerus when it is retracted posteriorly and the glenoid is exposed. The entire labrum is removed, and then through a series of steps, the entire capsule is released anteriorly, inferiorly, superiorly, and these include the origins of the long head of the biceps and the triceps. The glenoid can be marked, drilled, and then reamed in its preparation
There's that reamer we saw before.
for either a keeled or a pegged glenoid. In this case, a keeled glenoid is being used. The upper and lower portions of the keels are marked with a drill. These are connected with an osteotome.
Chisel.
The slot is compacted. And in this case, bone graft from the humeral head is used for impaction grafting.
Notice what he said there. They're using bone from the humeral head for impaction grafting to facilitate healing or adhesion of the prosthesis into its new location.
A triple cement impaction technique is then employed to decrease the radiolucent lines on the early postoperative X-ray. The keeled polyethylene component is then placed and impacted into place. The polymethyl methacrylate is allowed to cure, and then the
Methacrylate is super.
humerus is brought back to the deltopectoral interval. The center of number 2 fiber wire sutures are passed through holes in the lesser tuberosity and captured medially around the Holman retractor. The stem of the prosthesis is passed through this loop, the loops are tightened, and the stem is impacted into the humerus. Then the upper corner of the subscapularis can be repaired at the rotator interval and the lateral aspect of the subscapularis. Following this, these pre-placed sutures around the humeral stem are sutured into the subscapularis in an interlocking technique to facilitate more secure repair of the subscapularis and permit early motion.
Of course, those sutures are put into position before the return of the prosthesis, return of the joint, because the muscle and the tendons are more accessible. At this point, they would be far less accessible, and the intricate interweaving between the various tissues would be much more difficult to achieve.
Once these sutures have been placed along the entire length of the subscapularis, then the prosthesis can be assessed for stability. The deltoid pectoral interval can then be closed. Following the closure of the deltoid pectoral interval with marking sutures, the subcutaneous tissue and skin can be closed to conclude the case.
And the happy music returns. All right. So very similar to the hip replacement that we watched earlier. We're going to talk about the innervation of brachial plexus in more detail later. Now I just want to remind you of these terms you see up here, the dermatome, myotome. You should be familiar with those terms. The dermatome is defined as what? You've seen dermatomes, for example, these dermatomes here. Well, it's the region of skin innervated by a single dorsal root, sensory root, right? That's the dermatome. And so, for example, as we talk about the upper limb, you're looking at more or less the region of skin, and these are going to overlap. They're not as precise as the image would suggest. But you're looking at the region of skin that corresponds to each dorsal root. What is a myotome? Not skin this time, but what? Yeah, the muscles innervated. And myotome is used somewhat less specifically. The myotome usually refers to the muscles innervated by a ventral root, or in some cases just the muscles innervated by a nerve. But in any case, you want to be aware of the distinction. As a PA, you're going to be involved in tendon reflexes. We talked a little bit about spindle receptors in skeletal muscle that are monitoring the tension of the muscle, the degree of contraction of the muscle. There are also what are called tendon organs, or Golgi tendon organs, that are located in the tendons. Probably the best example of a tendon reflex that you'll be looking at is the patellar reflex. Now, there are little sensory structures in the tendons, and this would be true in the upper limb and in the lower limb. They would enable you to monitor, at least neurologically, if in fact those organs are doing what they're supposed to be doing. Are they monitoring the tension of the tendon? So in a tendon reflex, if we talk about the function of the Golgi tendon organ, basically what should happen in a normal, healthy individual, which I am not, which is why I'm having trouble even standing on one leg, is that when you tap on the patellar tendon, that should cause a reflex relaxation in the quadriceps muscle. Why would that be? Why would there be a reflexive relaxation as opposed to contraction? The idea is what that tendon reflex is doing is helping to prevent damage to the tendon by excessive abrupt contraction of the muscle. So this is just part of this whole sensory motor feedback system that must be functioning properly, really at all the joints, to ensure that the joint works properly and that injury under normal circumstances, or at least the risk of injury, is minimized. So we're looking at the brachial plexus, and as I say, we're going to go over the anatomy of this in more detail later. Now, with respect to the discussion of dermatome and myotome, I just want you to be aware of these general neural pathways, such that, for example, if C6, which you see here, is the region of skin that's innervated sensorially by the dorsal root at C6. It may not surprise you then if you follow that on down. Where's C6 there on the side? C6 would be, or you could evaluate the connection. I'm going to be careful here. The neural connection between the cord and the sensory tissue by looking at the palmar pad of the thumb. It doesn't tell you that if the patient doesn't sense the stimulus in the thumb, it doesn't necessarily mean there's a disconnection at C6. It just means there's a problem somewhere along that pathway, and at least you know the general anatomical trajectory of that pathway. So the ones in the boxes here are the ones you should know. You need to appreciate that, for example, C8 could be evaluated, or more properly stated, the neural pathway from C8 to the pad of the little finger could be evaluated simply by testing for sensation, tactile response there. And then down here, where we're talking about evaluation of myotones, very, very simply, you'll learn this with much more fidelity and detail later. Flexion of the forearm at the elbow flexion depends upon the integrity of the C6 motor pathway. Extension of the forearm at the elbow depends upon the integrity of the C7 pathway. And flexion of the fingers, these forearm flexors, depends upon the integrity of the C8 pathway. With respect to a general summary of function here, what we're going to find is the brachial plexus the spinal nerves will emerge from the spinal cord. Those roots, those spinal nerves will then coalesce. They'll come together at various points. They'll break apart into divisions and cords and so on. But ultimately, they will end up as nerves. And I have the major nerves that you need to know at the very least indicated here. And what we're talking about on this slide is the cutaneous sensation afforded by these individual nerves. And as a first approximation, as a very general simplification of the function of these nerves, again talking about sensory function, the musculocutaneous nerve affords sensory function to the anterolateral forearm. The median nerve to the palmar surface of the lateral three fingers, we'll talk about this in more detail later, but the lateral three fingers, by the way, in anatomical position, what is lateral? Would the thumb be lateral or the pinky be lateral?
Thumb.
So lateral three fingers, ulnar, the medial 1.5 fingers, and by the way, you'll learn about the radial on this side and the ulnar on the other side. So the radial nerve is the posterior surface of the forearm. In fact, the radial nerve is kind of easy because it's the posterior side all the way down from the arm to the forearm. With respect to motor function, again, is a very broad generalization. The anterior compartment of the arm is musculocutaneous. The anterior compartment of the forearm is chiefly the median. There are going to be some exceptions. The flexor carpi ulnaris, which enables you to sort of do that. The medial flexor digitorum profundus, I have to be careful which finger I pick, enables you to do that. Didn't know you could do that, did you? And then most of the intrinsic muscles of the hand are innervated by the ulnar nerve, the one that runs down this side. Posterior compartments of the arm and forearm, both sensory and motor function from the radial nerve. And this is just a brief reminder of the importance of C4, clinically C4. If you get into this region of the cervical cord, of course, the danger, anything superior to the danger of involving the phrenic nerve pathway to the lungs, and that could be life-threatening. All right, let's talk a little bit about the axilla. By axilla, of course, we're talking about this delightful region right under the underarm region there. And you can see that really what we're talking about is the region that, as I indicated a moment ago, is capable of changing its conformation and shape depending upon how you're moving your arm. And we want to talk a little bit about the medial wall, the lateral wall, the floor, and the apex of it. But in general, it's just this space that's between, and you don't really think about this space. You don't think about it being all that significant. But it's the space between your arm, your humerus, and your thoracic wall. So again, it's a rather limited space, but a number of critical neurovascular structures pass through the axilla. Now, remember we have structures passing from the thorax to the arm, and they do so over the associated skeletal structures such as the clavicle and the first rib. And in some cases, you have structures passing from the neck into this region as well. And that opening that you see, this region over here, would be called the axillary inlet. And we will elaborate on that. Now, in that quiz question today, I asked you about the order of structures from posterior to anterior in the popliteal fossa. Likewise, in this region, you should know the anatomical sequence that you would encounter from anterior to posterior in the axilla. So the vein would be most anterior, the axillary artery would be intermediate. And then sort of wrapping around to some extent, the artery would be the brachial plexus trunk. So the term trunk here has a very specific meaning. We'll talk about that a little later. But those would be most posterior and would be branching out from the neck. I think you already know from previous anatomy classes that the subclavian artery and vein become the axillary, and then the same structure will be subsequently termed the brachial. And the transition from the subclavian to the axillary occurs at the first rib, the outer or lateral margin of the first rib, and then the axillary becomes the brachial, if we're talking about the artery here, because the vein is going the other direction, at the margin of the teres major, the lateral margin, or outer margin of the teres major. I wonder why his voice disappeared. In any case, there are a couple of important things I want to point out in this little video because it's going to be hard to see these in the illustrations that you have.
Now we'll complete our picture by looking at three big external muscles: pectoralis major, latissimus dorsi, and deltoid. Of these, the first two have much in common. Pectoralis major on the front,
As he rotates here,
pectoralis major on the front,
so what is this up in here, this cavity? That's the axilla. Yeah, that's what we're talking about. And so I just want you to see, and he'll continue the discussion here, but we're going to talk about the anterior wall of the axilla. And in this illustration, what is the structure that primarily constitutes the anterior wall of the axilla? Pectoralis major. All right. And then the medial wall, would be primarily the thoracic wall that we see here. That's going to be largely, we'll talk about the composition of the thoracic wall toward the end of the course. And then the lateral wall. What would be the lateral wall as you look at this of the axilla? Yeah, the humerus and associated structures. The posterior wall is a little more complicated. I'm not going to worry about that too much, but I do want you to understand in general what we're talking about. I think this is a nice visualization of those structures.
and latissimus dorsi on the back. These two are alike in that they both pass directly from the trunk to the humerus, bypassing the scapula. Between them, they define the posterior.
And so there you see a beautiful image of this axillary region between the latissimus and the pectoralis.
And anterior walls of the axilla. Pectoralis major arises from the medial third of the clavicle, from the front of the sternum, and from the front of the first 6 costal cartilages. It's inserted here on the anterior edge of the bicipital groove.
So if that isn't evident to you, make sure you know the distal attachment of the pectoralis at about this point. Now, it's It's really sort of lateral there, but he's also showing an inferior placement.
It's inserted here on the anterior edge of the bicipital groove. Pectoralis major is a powerful adductor of the humerus. When its adducting effect is held in check by other muscles, it also produces internal rotation. Latissimus dorsi has a very
Lateral
wide
forward
origin.
is internal.
It starts here under the tail end of trapezius at T7 and goes all the way down to the sacrum and out onto the posterior iliac crest. It also has some fibers arising from the lower four ribs and occasionally from the tip of the scapula. It inserts here on the posterior edge of the bicipital groove. To get to its insertion, the latissimus tendon has to spiral around teres major.
So nobody says there, and we'll look at the attachment in just a moment, but it's sort of passing around the teres major to attach to the humerus. I think he shows us the attachment here in just a moment.
Here's teres major. Latissimus spirals from the back to the front with the lowest fibers of origin ending up highest. Latissimus dorsi, like pectoralis major, is a powerful adductor of the humerus. Acting through the humerus, it's also a powerful depressor of the scapula, powerful enough to overcome the whole weight of the body, as in doing a push-up. Last of all, here's the deltoid muscle. It completely surrounds the shoulder joint, from the front to the back. It arises from the spine of the scapula, from the acromion, and from the lateral third of the clavicle. It's inserted here on the deltoid tuberosity of the humerus. The deltoid muscle has multiple functions. It's almost like three different muscles. Its anterior part is a powerful flexor. Its posterior part is a powerful extensor,
I know those motions.
and its lateral part is a powerful abductor.
So what he didn't show that I wanted him to show there was the attachment of the pectoralis, but in the reposted slides, I put an image up there where you can see, if you don't, we'll quickly discuss it next time, the attachment of the pectoralis. All right, that's enough for today, so we'll stop there. As again, I'll post your grades as soon as I can.